So a toddler is lying in a hospital bed.
Okay.
They're, sleeping a lot. Maybe they vomited once or twice, and they have this tiny pinpoint purple rash on their chest.
Right, which is scary.
Yeah. And to an untrained eye, it might just look like a standard stomach bug with a little skin irritation.
Yeah.
But to a pediatric nurse,
That's a huge red flag.
exactly. Those tiny purple spots are a screaming, flashing siren that this child has hours, maybe even minutes, before their entire cardiovascular system completely crashes.
It is a massive emergency.
It really is. Welcome to the Deep Dive. Today, we have a highly specific mission. We are here to help you, the nursing student listening right now, absolutely crush the neurologic disorders section of your ATI RN Pediatric Nursing Proctored exam.
And we are pulling our battle plan straight from the source for this. We're using the RN Nursing Care of Children review module.
Specifically, chapters 12 through 15, right?
Yes, exactly. But we aren't just going to read you a list of symptoms. The exam tests your critical thinking, which means you really need to understand the underlying mechanics of what is happening inside the patient.
Okay, let's unpack this. If we are going to understand pediatric neurologic disorders, we need a working model.
Right.
So think of the pediatric central nervous system as the body's ultimate command center.
I like that.
But it is a command center that is still actively under construction.
Which changes everything.
Yeah, because it's still being built. It just doesn't respond to threats the way an adult brain does. It is incredibly vulnerable to swelling, to electrical misfires, physical trauma, and even fundamental genetic alterations.
And because it is under construction, you have to learn a completely different language of physical assessment to figure out what is attacking that command center.
Because babies can't just tell you what hurts.
Exactly. The exam is going to heavily test your ability to translate those really subtle pediatric signs into immediate, life-saving nursing actions.
Let's start with the most immediate internal threats then. Imagine an acute intruder that causes massive inflammation inside the command center. I'm talking specifically about Chapter 12 meningitis and Ray's syndrome.
Both terrifying conditions.
Right. With meningitis, we are dealing with an inflammation of the meninges, which are those protective connective tissues covering the brain and spinal cord.
Yes.
And the definitive way to figure out if that intruder is a virus or a bacteria is through a lumbar puncture to analyze the cerebrospinal fluid, or CSF.
And differentiating between viral and bacterial meningitis is a massive, time-sensitive nursing priority.
Because bacterial is so much worse.
Oh, absolutely. When you look at the CSF lab results, you are looking for a very specific metabolic footprint.
Here is how I visualize those lab results to keep them straight for the exam. Doing a lumbar puncture is, it's kind of like checking the fluid in a car engine.
That's a good way to look at it.
Yeah, if you pull the dipstick and the fluid is clear, and the glucose and protein levels are completely normal, you are likely dealing with viral meningitis.
Which is usually supportive care.
Right. But if that fluid comes out cloudy and the glucose is suddenly low, while the protein and white blood cells are elevated, it's bacterial.
And the reason that fluid gets cloudy and the glucose drops is purely mechanical.
Walk us through that.
Well, those bacteria are literally living organisms inside the spinal canal. They are eating the glucose for energy to multiply.
So they're literally stealing the sugar.
Exactly. And as they consume that sugar, they leave behind their metabolic waste and cellular debris.
Yuck.
Yeah, it's gross. But that waste drives up the protein levels and physically turns that clear fluid into a cloudy, purulent mess.
But before the provider even orders that lumbar puncture, as the nurse, you are the one performing the physical assessment.
Right, you're on the front lines.
And the textbook heavily emphasizes Brzezinski's sign and Koenig's sign. How do we keep the mechanics of those two straight in a high-pressure exam scenario?
It's all about understanding the spinal stretch reflex. The inflamed meninges act like a tight, severely sunburned string running down the child's back.
Ouch. A sunburned string.
Yeah. So for Brzezinski's sign, think brain or head. If you deliberately flex the child's neck upward-like, bringing their chin toward their chest, you are pulling on that inflamed string from the top.
And that hurts.
The pain is so intense that the central nervous system automatically fires a reflex to relieve the tension. It involuntarily flexes the child's hips and pulls their knees up to their chest.
So Brzezinski is bending the neck, which acts like a pulley, drawing the knees up.
Exactly. Now apply that same pulley logic to Koenig's sign. Think knee.
Okay.
The child is lying flat. You flex their hip and knee to a 90-degree angle, and then you try to extend that leg straight up into the air.
Which would stretch that string again.
Right. By straightening the leg, you are pulling that sunburned string from the bottom. The hamstring will violently spasm and resist the extension because of the pain radiating up the spinal cord.
So that resistance is a positive Koenig sign.
You got it.
And that brings us back to that toddler from the intro, the one with the pinpoint pupil rash.
The petechia.
Yeah, the text practically has flashing red lights around this. If you are assessing a child with suspected meningitis and you see petechiae or the purpuric type rash, you know, those tiny bruises that don't blanch when you press them, what is the immediate nursing action?
You implement droplet precautions immediately, like right that second, and you alert the medical team.
Because it's meningococcal.
Yes. That specific non-blanching rash indicates a meningococcal infection. The bacteria are actually causing microhemorrhages in the capillaries, which can trigger disseminated intravascular coagulation, or DIC.
Which is when their clotting just goes haywire.
Exactly. The child can progress to severe septic shock within hours. They need a private room, anyone entering must wear a mask, and they stay in respiratory isolation until they've had at least 24 hours of continuous antibiotic therapy.
The exam loves a priority action question, and isolation is always at the top of the list there.
Without a doubt.
Now, the other acute inflammatory condition highlighted in this chapter is Rey syndrome. It also causes acute encephalopathy, which is massive brain swelling, but it pairs it with severe fatty changes in the liver.
And the key exam trap for Rey syndrome is the trigger.
The aspirin, right.
Yes, it is inextricably linked to giving a child salicylates during a viral illness, particularly influenza or varicella.
The golden rule is never give aspirin to a child with a viral fever. But let's elevate this for the nursing student listening.
Okay.
The exam isn't just going to say the word aspirin. They will test if you know where salicylates hide.
That's a great point.
You have to educate parents to check the labels of over-the-counter medications because bismuth subsalicylate is the main ingredient in Pepto-Bismol, and salicylates are often hidden in topical teething gels too.
That catches a lot of people off guard. And think about what happens next when that inflammation takes hold.
What do you mean?
Well, when the pediatric brain experiences severe infections or the high fevers we see in meningitis, that intense metabolic stress can actually short-circuit the brain's electrical grid.
Here's where it gets really interesting. We are moving from the intruders to Chapter 13, the electrical storms. Seizures.
Yes, the electrical storms.
The text categorizes them based on how much the brain is caught in the storm. We have generalized seizures involving the entire brain, like the violent muscle contractions of a tonic-clonic seizure or the sudden drop attacks of an atonic seizure.
Right.
And then we have partial or focal seizures, which are contained to one specific area.
The pathophysiology of a seizure is basically a sudden, chaotic discharge of neurons. And while any seizure is a crisis, the exam focuses heavily on status epilepticus.
The really long ones.
Yes. This is defined as a prolonged seizure lasting 30 minutes or longer, or continuous seizure activity where the child never regains consciousness before the next one hits.
Why is that 30-minute mark so critical?
Because the brain is essentially running an ultramarathon at a sprint pace.
Oh.
During a seizure, the brain's demand for oxygen and glucose skyrockets. If the storm doesn't stop, the metabolic demand outstrips the supply.
So it runs out of fuel.
Exactly. The neurons literally begin to starve and die, leading to permanent, irreversible brain damage. Pharmacologically, you have to break the circuit with an immediate loading dose of a benzodiazepine, like IV diazepam or lorazepam.
I want to push back on the physical nursing interventions here, because the clinical instincts often contradict the textbook.
They really do.
If a child is actively having a violent tonic-clonic seizure, my first instinct, and I'm sure a terrified parent's first instinct, is to hold the child's thrashing limbs so they don't break a bone, and to wedge a padded tongue blade into their mouth so they don't swallow or bite their tongue off.
Which is completely understandable.
But why is the nursing text so incredibly strict about absolutely not doing this?
Because you cannot outmuscle an electrical storm, and trying to do so causes way more trauma. Yes. If you forcefully restrain violently contracting limbs against their will, you will cause bone fractures or severe soft tissue tears.
Wow, okay.
And regarding the airway, the masseter muscles in the jaw are clenching with astronomical force. If you try to force a bite block or an airway into a clenched mouth, you will shatter their teeth.
Oh my God.
You'll lacerate their gums or inadvertently push their tongue back and completely occlude the airway. You are mechanically creating the exact emergency you are trying to prevent.
So absolutely no restraints, nothing in the mouth. What is the actual priority then?
Environmental safety and airway maintenance via positioning.
Just getting them safe.
Right. Lower them to the floor, protect their head, loosen tight clothing, and crucially, roll them into a side-lying position.
To let gravity do the work.
Exactly. This allows saliva and vomit to drain out of the mouth, preventing aspiration. You time the seizure, and during the postictal phase, when they are exhausted and their reflexes are depressed, you keep them on their side.
And no water or anything right after.
Right,
the-
yeah.
it's-
Never. You never offer food or liquids until they are fully awake and the swallowing reflex is definitively back.
Got it. Now, to map these electrical storms, we use an EEG, an electroencephalogram. But the prep for this seems so specific, like the child's hair has to be washed, but you can't use any oils, sprays, or conditioners.
That's because the electrogel relies on strict conductivity.
Oh, so the oil blocks it.
Yeah, any lipid barrier from hair oil or conditioner will literally block the electrical signal from the scalp, rendering the test useless. You also withhold caffeine because it chemically alters brainwaves.
The text also mentions the technician might use flashing strobe lights or ask the child to hyperventilate during the EEG.
Which sounds scary.
It sounds totally reckless, intentionally triggering a seizure. Why did they do that?
It's a calculated stress test. Hyperventilation, for example, blows off carbon dioxide, causing systemic alkalosis and cerebral vasoconstriction. This actually lowers the seizure threshold. By intentionally inducing these specific triggers in a highly controlled medical environment, the neurologist can capture the exact moment the misfire happens.
So they can see where it starts.
Precisely. They can pinpoint the exact anatomical origin of the storm.
Wow. Okay, so we've covered the internal inflammatory threats and the electrical storms, but this command center also faces external physical trauma. Chapter 14, head injuries.
This is a huge chapter.
And I want to introduce an analogy here. The human skull is essentially a rigid, impenetrable, solid bone vault.
Right.
That is a brilliant evolutionary design for protecting delicate brain tissue from a baseball bat or a fall. But it is a catastrophic design flaw if the brain starts to bleed or swell on the inside.
Because there's nowhere for the pressure to go.
Exactly, because that bone vault has absolutely zero give.
This is the core of the Monroe-Kelly hypothesis, and it defines increased intracranial pressure, or ICP.
Walk us through that.
The skull contains three things: brain tissue, blood, and cerebrospinal fluid. If one of those increases, say from tissue swelling after a concussion, the others must decrease or the pressure spikes.
Makes sense.
In infants, because their cranial sutures haven't fully fused yet, the vault actually can expand just a tiny bit. That's why the early signs of ICP in a baby are a bulging or tense fontanelle.
The soft spot.
Right. Or they have an abnormally high-pitched cry, or the setting sun sign where the eyes are driven downward by the pressure and you see the white sclera above the iris.
But in older children, those sutures are fused, the vault is locked. So the early signs are different. They'll have forceful projectile vomiting without nausea, blurred vision, and extreme lethargy.
And the exam loves to test your ability to recognize when early ICP shifts to late catastrophic ICP. You have to know Cushing's triad.
The three late signs.
Yes. This is the physiological alarm bells ringing right before the brain tissue is literally crushed down to the brainstem, a process called herniation. Cushing's triad presents as severe systemic hypertension, profound bradycardia, and altered irregular respiratory patterns.
Wait, let's break that mechanism down. If the brain is under pressure, why does the body respond with hypertension, A&D bradycardia? It seems totally contradictory.
It does, but it's a desperate fight for survival. The swelling inside the skull is so severe that it is physically crushing the cerebral arteries, starving the brain of oxygen.
Okay.
So the brain panics and sends a signal to the sympathetic nervous system saying, pump harder, we need blood. So the heart clamps down the blood vessels, causing a massive spike in systemic blood pressure to try and force blood up into that rigid vault.
Okay, so that explains the high blood pressure.
Yeah.
But where does the bradycardia, the slow heart rate, come in?
The baroreceptors in the body sense this terrifying sudden spike in blood pressure and send an emergency signal via the vagus nerve to the heart saying, slow down, you're going to blow a vessel. At the same time, the physical swelling in the brain is actively crushing the brainstem, which controls your heart rate and your breathing rhythm.
So it's a total malfunction.
Exactly. The crushed brainstem loses its ability to regulate, resulting in profound bradycardia and chaotic respiratory distress. It is a system in total mechanical failure.
That is a phenomenal way to understand it, rather than just memorizing a bulleted list.
It really helps to know the why.
The text also mentions abnormal posturing as a late sign of ICP flexion versus extension posturing.
Yes. Flexion, or decorticate posturing, is when the arms, wrists, and fingers are tightly flexed and bent inward onto the chest. Think of bringing the arms to the core.
Decorticate.
Exactly. Mechanically, this indicates severe damage at the level of the cerebral cortex. The motor pathways are damaged, leaving only the flexor muscles dominating.
And extension is worse.
Extension, or decerebrate posturing, is much worse. The arms and legs are rigidly extended, wrists rotated outwards, jaw clenched. This indicates the damage has progressed deep down into the midbrain and brainstem. It is pure, unopposed extensor tone.
Let's apply this to a trauma scenario. The exam will undoubtedly throw a distraction at you. A child comes into the ER after a motor vehicle crash. They have a massive bleeding scalp laceration. What is the absolute first nursing priority?
The bleeding scalp is the trap.
I knew it.
Your absolute priority is to physically stabilize the child's neck and cervical spine until a spinal cord injury is definitively ruled out by imaging.
Because of the force of the impact.
Right. A head injury implies violent kinetic force, and where the head goes, the fragile cervical spine follows. The airway and the C-spine always take precedence over a surface wound.
I want to push back on positioning once they are stabilized. If the brain is starving for oxygen because of the swelling, my instinct would be to lay the child completely flat to maximize arterial blood flow to the head.
A lot of people think that.
But the interventions for ICP insist we elevate the head of the bed to exactly 30 degrees. Why?
If you lay them flat, you are trapping the venous blood inside the skull. The venous system doesn't have a pump. It relies entirely on gravity.
Oh, so it just pools up there.
Yes. Elevating the bed to exactly 30 degrees creates the perfect hydrodynamic angle. It allows the jugular veins to drain the excess blood volume out of the cranial vault via gravity.
Reducing the pressure.
Exactly. And it does it without being so upright that it compromises the arterial blood pumping up to the brain. You also keep their head perfectly midline to ensure those jugular veins aren't kinked.
It's literally just fluid mechanics.
It is.
And pharmacologically, we use mannitol for that, right?
Yes. Mannitol is a brilliant osmotic diuretic. It doesn't just make the child urinate. When infused into the bloodstream, it creates a highly concentrated hypertonic environment in the vascular space.
So it draws fluid out.
It literally pulls the excess water across the blood-brain barrier, sucking it out of the swollen brain tissue and into the blood vessels to be excreted by the kidneys.
Before we move on from trauma, we have to mention basilar skull fractures. The classic warning signs are bleeding from the ear, or clear fluid draining from the nose or ears.
That clear fluid is cerebrospinal fluid leaking out of a crack in the vault. You can test it for glucose or look for the halo sign on a piece of gauze.
And there's a big warning about tubes here, right?
A huge warning. If you suspect a basilar skull fracture, you never, ever insert a nasogastric tube or suction the nares.
Why?
The fracture could create a direct opening into the brain cavity. If you blindly insert a catheter, you could push it straight through the fracture and directly into the brain tissue.
Terrifying, but incredibly crucial to know for the exam.
Absolutely.
So we've navigated the acute crises, the infections, the electrical storms, the trauma. Now let's look at Chapter 15, transitioning from acute damage to chronic structural differences. Cognitive and sensory impairments fundamentally alter how a child perceives their environment.
What's fascinating here is the overlap between sensory input and cognitive development. If a child can't process sensory data, they can't hit their cognitive milestones.
Like with visual or hearing issues.
Right. The text highlights visual impairments like strabismus, which is the crossing of the eyes. If strabismus isn't corrected, the brain will eventually just ignore the visual input from the wandering eye to prevent double vision.
And that leads to permanent blindness in that eye, known as amblyopia, right?
Yes. And for hearing impairments, the exam focuses on subtle developmental cues, like an infant who lacks a startle reflex to a loud noise, or a toddler who speaks unusually loudly and avoids social interaction simply because they cannot process auditory cues.
But the heavy hitter in this chapter is Down syndrome, or trisomy 21, and I want to zero in on the nursing care specifics, because some of them seem really peculiar if you don't understand the underlying physiology.
They definitely do.
For instance, the text emphasizes swaddling the infant to prevent heat loss and using a long-handled spoon for feeding. I usually associate swaddling with comfort, not clinical temperature control. Why is thermoregulation such a specific issue for a child with Down syndrome?
It comes down to muscle tone. Children with Down syndrome frequently present with severe hypotonia or muscle weakness.
So they're kind of floppy.
Yeah. A typical newborn has strong flexor tone. They naturally pull their arms and legs in tight to their core, which conserves body heat. But an infant with hypotonia lacks that flexor strength. When you lay them down, their limbs fall outward into a limp, fully extended, splayed-out position.
And because they are splayed out, they have significantly more skin surface area exposed to the ambient air.
Exactly. They lose vital body heat incredibly rapidly through convection and radiation. So swaddling isn't just a comfort measure, it acts as an artificial flexor tone.
It essentially does the work their muscles can't do yet.
Right. It forces their limbs into a heat-conserving posture, making it a critical clinical necessity to maintain their thermoregulation.
That perfectly explains the swaddle. Now, what about the long-handled spoon?
A characteristic physical feature of Down syndrome is a protruding tongue. This makes feeding incredibly challenging because the infant's natural mechanical reflex is to thrust the tongue outward.
Which would just push the breast milk or formula right back out of their mouth.
Exactly. By using a long-handled spoon, the nurse or the parent can physically place the food further back on the tongue.
Oh, I see.
This simple mechanical adjustment bypasses that initial thrust reflex and directly stimulates the swallow reflex at the back of the throat.
It's amazing how a slight change in the angle of a spoon fundamentally alters the neurological feeding reflex. What systemic complications are we monitoring for on the exam?
The priority is cardiac. About 40 to 45% of children with Down syndrome are born with congenital heart disease, particularly septal defects, so early echocardiograms are mandatory.
And respiratory issues too, right?
Yes, they are highly prone to respiratory infections. Because of that hypotonia we discussed, their intercostal muscles are weak, meaning they can't cough effectively to clear secretions.
Which is a setup for pneumonia.
Combine that with a flattened nasal bridge that impairs mucus drainage, and yeah, they are constantly at risk for pneumonia. Finally, that decreased muscle tone also affects the smooth muscle of the gut, severely decreasing peristalsis.
So digestion slows down.
Significantly. A high-fiber, high-fluid diet isn't just a recommendation, it's a medical requirement to prevent chronic, severe constipation.
So what does this all mean? We have covered a massive amount of ground to prepare you for this exam.
We really have.
We've learned that understanding the pediatric brain requires recognizing the metabolic footprint of meningitis in a cloudy CSF sample.
Yep.
It means fighting your clinical instincts and knowing exactly how to protect an airway during the severe metabolic demand of a seizure.
Don't restrain them.
Never. And it requires managing the fluid mechanics of a rigid cranial vault by elevating a bed to exactly 30 degrees to manipulate gravity. And of course, it means fundamentally adapting your physical care to support the unique hypotonic physiology of children with structural differences.
If we connect this to the bigger picture, I want you to consider how seemingly mundane nursing tasks are actually profound neurological interventions.
That's a great way to phrase it.
Choosing to use a long-handled spoon, measuring the exact degree angle of a hospital bed, or deciding when to swaddle an infant. When you realize that every single physical adjustment you make actively changes the fluid dynamics, the electrical stability, and the sensory processing of a child's developing brain, your routine care suddenly becomes a powerful, exacting science.
This raises an important question for you to mull over as you close your textbooks today. We've spent this whole session talking about managing neurological crises and structural deficits. But the pediatric brain possesses a superpower that adult brains simply do not have: extreme neuroplasticity.
It's unbelievable what their brains can do.
Has you ever looked into a pediatric hemispherectomy? In cases of uncontrollable catastrophic seizures, surgeons can physically disconnect or remove an entire half of a child's brain.
Half the brain.
Yes, and yet because the command center is still under construction, the remaining half of the brain can literally rewire itself. It will adopt the functions of the missing hemisphere, allowing the child to walk, talk, and live a functional life with only half a brain. It's a level of physiological resilience and adaptation that science is still trying to fully comprehend.
It is truly the most remarkable organ in the human body.
And that is the level of awe and mechanical understanding you need to bring to this exam. You aren't just memorizing facts, you are learning the engineering behind the most vital, vulnerable command center we have.
You're going to do great.
We wish you the absolute best of luck on your ATI RN Pediatric Nursing Proctored exam. You've got this. Thanks for joining us on this deep dive.